Hello, everybody. My name's Ed Pavlik. I'm in Lexington, Kentucky. It's quite snowy and icy here. My colleague today is,
Frank Lawton in London, UK. It's cold. We haven't had snow, but it's cold and wet and miserable. Although the daffodils are beginning to come through the ground, which is telling me that spring's on its way, I hope.
well, Frank, every time I prepare for us getting together, I try to look up something that's happening in the UK, and I go to the BBC and I saw something about trouserless Tuesdays in the tube.
Oh, yes.
I don't think that's my kind of January fun.
I was on the tube at the time it was supposed to happen, and I have to say I didn't see anybody who was dressed in just his shorts or his whatever. But yeah, there they go. Yes, yeah, yeah, very exciting, isn't it? I've no idea what it's about. It's a bit like I when people after a Christmas and New Year when they've overdrunk and they have a dry January, I think it's the same thing. I think it's just people, it's an excuse. I certainly wouldn't do it in January, not in London. The tube is quite warm, there's no doubt about that. But you've got to get up and down the tube and up and down the stairs and the escalators and outside, and it is a bit it is a bit cold for that, I think.
I bet it's drafty too.
Oh, absolutely, yeah. Yeah,
Well,
and I don't know whether they go to the pub afterwards when dressed like that,
oh,
or even go to work like that.
I
Yeah,
think they went before.
you could be right. Yes.
Well, today we're going to consider the question, is an artificial intelligence approach available for using MRI to obtain comprehensive preoperative predictions of prognostic factors in endometrial cancer? Uh, this paper that deals with this is titled Artificial Intelligence Enhanced Magnetic Resonance Imaging-Based Preoperative Staging in Patients with Endometrial Cancer. It appeared in the International Journal of Gynecological Cancer. Frank, what do you think of this paper?
I I rarely have real problems with papers, but this one I think is extremely lightweight, and I feel that they're trying to hide something, or they are claiming things that the paper does not support, or they're in some way obfuscating in what they're doing. The idea is that the MRI assisted by artificial intelligence will detect greater degrees or more subtle degrees of myometrial invasion of the tumor or cervical stroma invasion, both of which are obviously important prognostic factors. So they've looked at 178 patients, which is not huge, but it's a real good enough numbers. And they've asked two experts, and I put experts in inverted commas here, to review the imaging. And the expert is one subspecialty fellow or consultant in pelvic imaging, which I think is perfectly reasonable. The other is a gynecological oncology surgeon. And I don't remember as a gynecological oncology surgeon asked very often to look at radio MR images of endometrial carcinoma before I was going to operate. I would refer to my radiology colleagues to tell me that. So I'm not really sure what the idea of having a surgeon to look at that. However, that's what they've done. Interestingly, in this study, they excluded patients that had significant MR artifacts. And in a way, that's part of the problem, isn't it? That if you've got an MR artifact, is AI going to be able to overcome that? And they haven't looked at that question. So clearly, there are a number of images that they weren't going to expose the AI program to because they felt that it probably wasn't going to give the right answer. So in the end, they looked at myopenetration and cervical stroma and compared it with what the experts say and gave what they call a balanced accuracy. And I've got the numbers here, and I think, Ed, you may well have them, that the accuracy of myometrial penetration by the experts was 0.769 compared with 0.702 for the deep learning. Now, that looks better for the radiology expert than the deep learning. The same for the cervical stromal invasion, 0.859 versus 0.721. So in both instances, the clinician, the human, does better than the AI. What they then looked at is what's called the DICE score, and sadly, they don't actually explain what a DICE score is. They only mention it on the fourth page of the report, and I think it's quite important about what the DICE score is. And I think, Ed, you've got some information about DICE scores,
Yeah,
which might be helpful here.
that's right, Frank. Let's say the simplest way of looking at it is the way I have it up right now, and they're looking for scoring overlap. And the way they've done that is to say there's a blue box and a green box, or excuse me, a brown box and a green box, which could be, pixelated in the digital sense. So you could count the number of pixels in each one of those boxes. And when you do that and see how you score, for instance, if the brown box here happened to be the malignancy, and the green box the uterus, then you would see how much overlap was between what was being analyzed by a score. So they take the overlap region, which here is the blue region, and multiply it times 2, and then divide it by the pixels in both the brown and the green box, and they get a number that comes out to be that score. So when you do this, several things come to mind. One thing is what in the world uh, would you expect from the best expert, which would be maybe 10 radiologists, and what would you expect from the worst? Now, there's no overlap when you get a DICE score of 0, and 1 is perfect overlap. So if we get back to that model where I had the brown box and the green box, I'll point out that if one of those boxes is outsized, much bigger than the other, it's going to affect the calculation of the DICE score. And certainly the uterus would be expected to be much larger than the lesion. And that's going to put you in a little bit of a bias with regard to how the score comes out. Now, it always means that there's a factor in the denominator that's much bigger than the factor in the numerator. And then we all know that the denominator can drive numbers, pretty much. Back to you, Frank.
Yeah, well, there we go. So they imply, and the numbers suggest, because I think the DICE score is I can't remember what it is, anything above 0.7. And I think it's accepted that suggests that the linkage is appropriate. So the DICE score does seem to be something that they can claim is useful in AI and imaging. However, going back to their claims about the degree of myometrial penetration, cervical stromal invasion, I don't think these data, in fact, the table is there. These data do not support the conclusion, and the authors say the accuracy of the developed deep learning model is higher than the human evaluation in detecting deep myometrial invasion, but not cervical stromal invasion. But the table that you've just showed doesn't suggest that at all. It's either they've not read it, or the data was put there before the manuscript was finally accepted. But the data are completely wrong, unless I've missed something, which is possible. The other interesting thing, I think, is they've compared in a meta-analysis of over 40, 50 studies, looking at the sensitivity of detecting myopenetration based on just presumably radiological findings and cervical stromal invasion, and the accuracy, the sensitivity with the machine learning, with AI, it falls within what they've been reported in the meta-analysis. So I think in review, clearly imaging is perfectly is a perfect example of how AI can work. In the end, is the pixel positive or negative for whatever we're reading, whether it's traffic lights or people or depth of millimeter penetration. And I think that in time, then AI will certainly aid very much so in the diagnosis and the staging of many diseases. Unfortunately, and you've got to put the marker somewhere, and I think this paper's got some data, but I think the data is so flawed that really I don't know how this paper was even accepted for publication, to be honest. It's not good.
And plus, it was put into a pretty good journal. So,
Yeah, but interestingly, not a radiological journal. It was the IGCS journal is being read mostly, I would have thought, by gynecological oncologists or radiation or medical oncologists, not by not radiologists. So why this was put in the IGCS rather than a radiological journal, I don't know. It's a very unusual paper, and I really don't know how it found a home in such a journal like that.
well, exactly. It also raises sort of a question that you first touched on, and that's that who do you choose for your human comparators? If you're asking a different total type of question, which is how does AI compete with doctors um, uh, relative to answering a bunch of questions? Okay, say 500 questions, 500 board exam questions. Well, how many of those doctors are destined not to pass the board? How many of those doctors pass at a very high score, and how many pass due to the cutoff score just for passing?
Mm.
And that's
Yeah.
going to determine how good the machine or AI really performs. And here you've got two individuals, and
Yeah.
one of which is not a radiologist. So it's
Yeah. 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 Yes, I don't think the paper should have been published in that journal in the way it has been published. I think that's a reasonable way of putting it. The data are there, but I think that either the interpretation or the reporting is erroneous, and that's dangerous. That's difficult, I think.
That's right. Well, we're not going to beat this horse to death. It's already dead. So it's good to be with you, Frank, and we'll do it
Okay.
again in a month. You take care.
And you. See you soon.